Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thanks, Brian. The last time I was on, this was news to me. I was not involved with any of the review of these guidelines, which were published in its Infection Control and Hospital Epidemiology in September, I believe. And this is an update from the guidelines from 2013, which were updated from 2005. There are no medications that are FDA approved for the use of post-exposure prophylaxis, neither as occupational nor as non-occupational post-exposure prophylaxis. No medicines are FDA approved for these indications, and I personally have no conflicts of interest. This is our disclaimer slide. This is a clip of what the new guidelines look like with the link you can find at the bottom. I decided that I was going to take you through this looking at what the past guidelines said, so the 2013 guidelines that were published in the same journal, as well as the recent non-occupational post-exposure prophylaxis guidelines that I did review and were published finally earlier this year. So I'm hoping that this isn't too confusing. If I say anything that is confusing and you aren't certain which guidelines are saying what, please let me clarify, because I tried to make this as clear as possible, but it may not have succeeded. We'll see. So this is the TLDR version of what's new in the 2025 Occupational Post-Exposure Prophylaxis Guidelines. There are new regimens that shouldn't be a surprise. There is a recommendation for a shortened duration of follow-up testing after the exposure, some elimination of routine lab tests for toxicity, and some considerations for source patients who have undetectable HIV RNA. They invited the authors of the non-occupational post-exposure prophylaxis guidelines to contribute and tried to harmonize them as much as possible, which I thought was super helpful, so that maybe at some point our PrEP guidelines and our 2 PEP guidelines might have similar recommendations and we don't have conflict between the two. So I'll try to highlight where there are similarities and where there are differences. This is their stated emphases, which have not changed in this version. So the first is primary prevention of exposures. We don't have to talk about post-exposure prophylaxis if someone doesn't get exposed in the first place. The second is reporting to occupational health, wherever that may be for you, and initiation of PEP as soon as possible. They try to focus on the best tolerated PEP regimens with the fewest side effects. We're doing this for prophylaxis. We're doing this for treatment. Attention to drug-drug interactions, consultation with HIV experts for complex cases. They comment about HIV testing for source patients without delaying PEP, and then specifically about some of the counseling messages and follow-up. So this is the emphasis. Again, this has not changed in these new guidelines. So one of the things I thought was interesting is looking at, so what do they consider an at-risk exposure? So in these guidelines, they talk about 3 main categories. The first is percutaneous injuries, things like needle sticks. And they say that the risk of transmission associated with a needle stick injury is on the order of 0.23%. You can see the confidence interval there. They also say that at-risk exposures include contact of mucous membranes or non-intact skin. There's an estimate for what the chance of transmission is for contact of mucous membranes, which is about half of the needle stick injuries, and there's no estimate for non-intact skin. And then they comment about human bites, which there has been a case of transmission that has occurred not from an occupational exposure, but from an in-home exposure to a human bite. So the things we know, so first about this is that we know that the risks for any of these is higher if the source has a high viral load. For needle sticks, we know if there is a deeper needle stick with a larger bore needle with more blood in it. And the thing I have in red, and that's what you'll see on my slides, is when the other guidelines differ. And so from the non-occupational PEP guidelines, which I'll abbreviate as NPEP, that for contact of mucous membranes or non-intact skin, they discuss case-by-case determination or shared decision-making. Shared decision-making is going to come up quite a lot in these guidelines. And then in the post-exposure prophylaxis for bites is not routinely recommended. So going back to the occupational guidelines, other body fluids that might be potentially infectious include blood and visibly bloody body fluids, semen, preseminal fluid, vaginal fluid, rectal fluid, and breast milk, CSF, and all the other fluids you can see listed there. And then things that you should not consider infectious unless they are visibly bloody include urine, feces, vomitus, nasal secretions, saliva, sputum, and sweat and tears. The next that I think is interesting and to see where the difference is about the timing of PEP. This statement that initiation of PEP after exposure is an urgent matter is consistent with the past guidelines. And this is the statement. So initiate as soon as possible, up to 72 hours following the occupational exposure. And when considering initiation longer than 72 hours, where there is a risk of transmission, you should consult a provider with expertise in HIV treatment. And again, that red highlighting you'll see from the other guidelines, that should be the 2013 guidelines, specifically that you could consider initiating PEP after a longer interval, up to a 1 week, if you have an exposure that is considered at extremely high risk. And the NPEP guidelines are really clear. One, that it should be no later than 72. And one of the things we tried to emphasize is that it really is an urgency or an emergency and should be within the first 24 hours. And this, of course, is from animal data. That's all we have data for, where there was no benefit after 72. And really the benefit of post-exposure prophylaxis cuts off quickly after the exposure. So it really is an emergency, and we want to get people as soon as possible. So I thought it was interesting that the occupational PEP guidelines didn't include this sort of 24-hour window as a priority, even though they are continuing to say that it is urgent. This is about the source patient and testing the source patient and the potential source for the exposure. So this recommendation is not changed. Determine the HIV status of the source patient whenever possible, but do not delay PEP while waiting for this determination. They specify that point-of-care testing is recommended for speed. They don't say you should wait or consider the window period except when there is clinical suspicion of acute HIV infection. Just because there have been no transmissions that have been reported among people who tested, where the source patient tested negative for HIV by a point of care other test, but they were truly in a window period for whatever test they were using, there were no cases reported. And so the occupational guidelines feel comfortable saying the source patient can be tested with a point of care test in order to get information as soon as possible. Because if you'll skip down to the bullet point, if the source patient tests negative, then you do not need PEP or any follow-up testing for HIV. There's a specific recommendation not to test any needles or any other sharps that might have been the source of exposure for HIV. And then the note that in the NPEP guidelines, that in fact, when you have someone who encounters a needle stick in a park or something like that, that NPEP is not actually even recommended unless there are exceptional circumstances. For those of us who get these PEP questions, this comes up fairly frequently. My kid was in the parking and stepped on a needle. Unfortunately, these things happen. But again, PEP generally not recommended. Whereas, of course, in a hospital exposure, when this is someone's job, that they would recommend doing PEP in those cases. And so again, this is one of the places where you see the differences between the occupational PEP guidelines, where someone is exposed in the context of their job, versus a non-occupational exposure, which is less likely to sort of emphasize the provision of PEP. And then if you know that, jumping down the last bullet, if you know that the source patient has drug-resistant HIV infection, the recommendation is to consult a provider. But if you can't get the provider, expertise immediately. Do not delay any PEP, and then you can later modify PEP. Again, trying to emphasize the urgency of PEP. There is a lot about shared decision-making, as I hinted to earlier, and consulting a provider with expertise. And I've listed all of them here. The first is, as they've highlighted, that there are now new recommendations for occupational PEP with source patients who are known to be living with HIV but have undetectable viral loads. But you're supposed to consult a provider with expertise in HIV treatment. The reasons for the why you might not necessarily give occupational PEP to someone who is exposed to a source patient who had undetectable HIV RNA levels is based on the U equals U, undetectable equals untransmissible, which is based on sexual transmission. But also we know that in the original studies of needle exposures, that your risk of transmission was higher with higher viral loads, lower with lower viral loads. And so this is where you might not have the recommendation necessarily. But again, consult with expertise in HIV treatment. And then interestingly, again, in the NPEP guidelines, that if you have someone who was exposed to someone who is HIV positive but undetectable, that non-occupational PEP is not routinely recommended. Again, the difference between occupational exposures and non-occupational exposures. Consult a provider with expertise if your source patient is unknown, if your healthcare provider is taking PrEP or has received cabotegravir as PrEP in the last 12 months. In the NPEP guidelines, PEP is not recommended for someone on PrEP. That's what PrEP is for. But again, with the occupational exposures, we may have a different level of risk tolerance. And then finally, consult your provider with expertise in HIV treatment, which of course all of you are anyway, for pregnancy, breastfeeding, renal dysfunction, hepatic impairment, or any problems, intolerance, or toxicity with your PEP regimen. What to use? This is actually completely consistent with the non-occupational PEP guidelines. They've changed from a raltegravir-based regimen to a bictegravir-based regimen or a dolutegravir-based regimen, entirely based on convenience, once-daily regimens, and much better tolerated. You can see that as an alternative, you can use boosted darunavir, boosted either with cobicistat or ritonavir, but it's still acceptable to use a twice-a-day raltegravir-based regimen. And then, of course, the same, do not use nevirapine. There's a greater risk of hepatotoxicity. And there are some animal studies using the two-drug cabotegravir plus rilpivirine, where there have been some breakthrough infections. Again, animal studies. But again, recommended occupational, and I think we're probably already doing this. Most of you are probably already doing this, and now it's officially in the guidelines. Baseline laboratory testing will look pretty similar to what you've done in the past. This is for the exposed patient. So an antigen antibody HIV test, either point of care or lab-based, an HIV NAT if they received CAB for PrEP in the last 12 months, with the comment that they prefer a qualitative NAT due to the higher sensitivity at low RNA levels. We're going to check creatinine and 2 liver function tests, your AST and ALT, and they don't list pregnancy and hepatitis B as in boy and C as in Charlie in this document, but there are separate guidances for those, and I've listed those at the end of the slide set. And then counseling messages, again, aren't going to be any different than what you've been doing. It's the importance of taking the PEP, including every one of these doses, precautions to prevent secondary transmission to sex partners and other folks until final testing is complete, about side effects and drug-drug interactions so people know what to expect, symptoms of acute HIV infection, the fever, rash, sore throat, muscle aches, joint aches, and someone should come in for testing if they have any of those symptoms, and a recommendation for a reassessment and a check-in at 72 hours just to see how symptoms are going and to reinforce adherence if someone is going to continue to take PEP or to provide results of HIV testing the source patient if that wasn't available at the time of the initial appointment. Follow-up laboratory testing. Here is where there's a few things that are different than what we've done in the past. So again, we just did baseline testing. This is again of the exposed person. At 4 to 6 weeks, there's a recommendation to do testing only if someone started after 24 hours after their exposure or they missed any doses. And this is similar to the non-occupational PEP guidelines that make that 4 to 6 week HIV testing optional. And then in these 2025 guidelines, the recommended final test is just at 12 weeks post-exposure, so 8 weeks after stopping your PEP for an antigen antibody test and, again, a nucleic acid test. Again, similar to the non-occupational guidelines. Repeat creatinine and LFTs are only recommended if they were abnormal at baseline or there's some reason to suspect that there may be some abnormalities based on comorbidities or symptoms. And then, as I mentioned earlier, if someone has had any symptoms of acute HIV infection during this entire time, they should come in for a lab-based antigen antibody test and NAT. This is just the links for the hepatitis B, hepatitis C, and pregnancy guidelines that I mentioned.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.